Hey guys, welcome to What the F. Today's episode is amazing because we are going to break down what the F is a rescue med. And if you're listening to this and you're like, I don't know what you're talking about, don't worry, you are in good company. I am very ignorant around this topic. And I think a lot of people in the epilepsy community living with epilepsy are like, I don't know what that is. Or I've heard of it, but I don't know if that's for me. And today we have a very dope neurologist who is also an epilepsy advocate who's going to break down what a rescue drug is, what that means, who should use it, what to ask your doctor, all of the things that kind of like insider tips. So it's going to be an awesome episode. And there's also a survey that you can take at the end of this episode. It's in the episode description. You can take it now too if you want, just to see how much you know about rescue meds. And also everyone who takes a survey, it will be entered to win some cool epilepsy merch. There's more info about it at What the F Podcast Instagram page, so check it out. And here we go. Before we get started, I want to thank our community partner, Epilepsy Foundation of America, and sponsors Neurelis and SK Life Science. Thank you so much for believing in this podcast, for making conversations like this possible, and giving us a space to talk about our epilepsy what the F moments. Okay, here we go. Okay, today with me, I have Dr. Danielle Becker. She is an adult epileptologist, a division director of epilepsy at the Ohio State University Wexner Medical Center, where she is also an associate professor. Danielle, thank you so much for being here.
Thank you so much. I am honored to be a part of your podcast and to get to speak to all your listeners as well.
Well, I am just so excited because you have such an amazing background as a neurologist and an epileptologist and a professor. I looked at the title. I'm like, does she have any free time ever? What? I was like, this is as if there wasn't enough. We're gonna be a professor as well. Okay. I'm like, amazing. And so and I really appreciate just all of your advocacy around talking about just not only epilepsy awareness, but rescue meds in particular. And I think it's just something that I know I can speak from my experience is something that I need to learn more about. And I just appreciate just where you are coming from, because you have such an interesting background, which I think is very worthwhile in sharing before we dive into rescue meds. And your background is in neuropsychology, because we had one conversation before and I fangirled out on that. And I would love if you could just, explain what neuropsychology is and what your background in that looked like and how that led you to be an epileptologist.
So of those of you out there who may have had surgical workups or even just cognitive issues with your epilepsy because of the meds, the seizures, you may have gone for neuropsychological testing. And what that is it's a battery of tests that try to help figure out where you may have deficits or where you may not be performing up to the ability that you have in the past. And the idea is not only to try to identify where there might be an issue, but also to give recommendations of how to treat that or how to compensate for it. And so when I did neuropsychology, I loved it. I loved the relationships I had, and I liked making all these recommendations. But then the person you're treating gets passed to a neurologist, and you may not see them again after the recommendations you've made. And that was very hard for me because you spend, as many of you may know, 6 or 8 hours with someone, really getting to know them, getting to know part of their journey, and then not getting to really see the implications of what you recommend. And that's really what made me want to go back to medical school and actually be a further part of that journey.
Well, it's so interesting because I've done the neuropsychology testing. And I remember I think for me it was 5 hours or something of just very intense brain games. I don't know how else to describe it. And yeah, and it never really occurred to me that I was never going to see this person again. It just never, I didn't really think about it. And then until later, bye. Okay. And so I could see how on the flip side too, there must be some feelings about that as well. I also love how this was the thing that inspired you to go back to go into med school. That's amazing.
Yeah, I mean, I feel very lucky. And I also feel that because I got to see that side and I got to actually do psychotherapy as well, it made me a better doctor. It made me a better provider. And it also helped me relate more to what our patients may be going through and to ask questions, because if you don't ask, you will not know. And for you all out there, if you don't tell us and we don't ask, we will not know. So I always kind of approach it from both sides. We as providers should be asking, but if you have a provider who doesn't ask, then you need to speak up.
Which is hard sometimes to do. It's, and I think that gets talked about a lot on here, is it's like sometimes it's just this sort of like, I don't know, you feel like a little cowering in front of your doctor, and like silly asking questions and stuff. But the fact that you have a background in neuropsychology, because I have been seeing a neuropsychologist for psychotherapy for, I don't know, like 5 or 6 years now, and to have someone who understands epilepsy and can explain what is happening in my brain and why my emotions, for me, my emotions are very attached to my seizures. And so like, it was life-changing. It was absolutely life-changing. So then I'm like, okay, so then there's a neurologist with a neuropsych background. That's insane. That's awesome. And you said it made you a better physician. And, can you describe maybe some of the, like some of the experiences you had with doing psychotherapy in neuropsychology and like how that made you a better doctor?
So I ran a support group last night, and the person who organizes it has epilepsy. And so she asked me the toughest question. She said to me, what is your advice when someone may have just had a seizure and they don't feel well afterwards and they don't feel their self and they might feel snippy or, in a darker place? And I actually had to pull from my neuropsychology background. And I said a couple different things, but I used to teach like relaxation breathing and deep breathing and how to try to, get rid of negative energy and bring in positive energy. And I actually described that to them last night. And then I also said, have things in your life that make you happy. Like I know you just got married. So, looking at your wedding pictures or a trip you just went on, or if you have, an animal, a pet, a child, a best friend, like someone that you just hug, or you can pick up, like someone that you pick up the phone and they always make you smile. And it's those things, and even answering that question and making me step back for a second, I think that I'm constantly pulling on the tool bag that I learned as, I wasn't a full psychologist, but learned as training in psychology. And I think that it helps give me a little bit of a different perspective. And especially the deep breathing, I feel like I teach people, once a week at least in my office visits, because we know that depression and anxiety are very common in patients with epilepsy, and especially those with drug-resistant epilepsy, it's over 50 to 60% at least. And I think that's still an underestimate.
I believe it. Because, I feel like it's just one of those things that just like is part of epilepsy at this point, from a very like anecdotal point of view, from no research. I have no research to back this up other than the people I've talked to. But it's so funny you say that, just because you say like you're, pulling on your toolbox of neuropsych. And as you said that, think of all of the things that like, make you happier and stuff. So my neuropsych helped me come up with a plan for after a seizure, where I literally just pull out this file folder, and it's like, here are the movies you like, here are the friends you can call, here are the takeout places you can order from. You will be feeling depressed. It's okay. It will pass. I promise you. And and then I have birthday cards in there. I have, I just keep like everything in there, like sweet notes from my husband, and like just to because like after a seizure, I can't remember what brings me joy. I can't remember that stuff, but it is like the best advice to just go to it and remember that even if in that moment it's not bringing you the most joy, it will again, So I literally have chills thinking about how you are able to provide that advice, and those tools to people now based off of like what your training was, years ago. I think that's just so amazing.
Thank you. I appreciate it. And I like being able to share it too, because I think it is a little bit of a different perspective, but an important perspective.
Yes. Absolutely. Absolutely. But so now you are an epileptologist. I'm like med school happened, boom, because you probably kicked ass in med school. And then, you started practicing neurology and epileptology. As you're talking and explaining all of this, what is the thing that drives you to pursue such passionate work with patients with epilepsy? Because your work is beyond the clinic. Like you just talked about a support group that you did yesterday. Like, what is the thing that drives you?
As you can experience this firsthand, epilepsy can be a devastating disease, but it also plays on people's most vulnerable moments. And so epilepsy is scary because of the seizures, but epilepsy is also scary because you don't know what it is. You don't know why. You don't have answers. And so for me, if I can listen. So number one, if I can even just provide someone who's listening, or an explanation, or an answer, even if it's not the answer, because even saying something isn't a seizure is an answer. I think the hardest is a lot of people want to know why they're having seizures, and we don't always have those answers, but acknowledging that we don't have the answers is important too. So for me, taking a disease that is so scary and steals independence, if I can be a partner in that journey and help people, that it gives me purpose.
Well, thank you. Thank you for your purpose. I appreciate your purpose. I do. I know it sounds so cheesy and weird, but I do. And so, okay, so now we're going to fast forward again. Now you are the director at the Ohio University, and which is just amazing. So, and you're also a professor and you're still a practicing doctor, which is just, and leading support groups. Let's not forget that. So what do you feel like your role is now?
So I thought, as being a division director of a Level 4 Epilepsy Center, I'd have a louder voice. I thought that I might have a little bit more support for the expertise or for the conversations I wanted to have.
Mm-hmm. Make some noise, and you're making it. It's amazing. And okay, so speaking of noise and making noise, we're going to talk about now. I just am dying to talk to you about rescue meds, because this is something that I feel, I don't want to say embarrassed because I'm just putting it out there, but I am very ignorant about rescue meds. And I remember the first time I heard that term wasn't even from a doctor. It was from a friend. And she was like, "You've never heard of that?" And I was like, "Shit, no. Like, what do I need to know?" So I just want to start with like the basics of like, what is a rescue med in the
Absolutely.
epilepsy
But I'm going to
world?
back up for a second and tell you, as an adult epilepsy provider, I was probably somewhat ignorant of rescue meds as well before newer, more accepted formulations came out. So just to back up, there was a rectal rescue medication that's been out for 20 years. But then at the end of 2019 and beginning of 2020, two other rescue meds came out that were a nasal formulation and that are FDA approved for the use of trying to stop a seizure. And we'll talk about that in a second. Yeah.
So this is
No,
new.
it's not new.
But I think 2019
That's
is
new.
new.
So the rescue medication concept has been around for over 20 years because they have had one FDA-approved rescue medication that was a rectal diazepam. That has been out since 1999 or 1997 or 1999. So it has been tried and true and used for over 20 years, but it's a rectal medication. So, in fact, you'll hear sometimes that people will say, wait for the seizure, wait for it to last 5 minutes, because if it lasts over 5 minutes, it's unlikely to stop, and then give the rescue med. I'm telling you that because that's not what I do. But I think that came from a world where the rescue medication meant that someone had to have their pants pulled down in front of other people and be given something rectally, which can be worse than the seizure itself. And in this day and age with like phones everywhere, it absolutely probably is worse.
Oh God. Yeah. No one wants to even hear it. Like, honestly, it's just like, it just sounds like another nightmare on top
Right.
of a seizure, you know, especially, and like also just the process of that, when someone's having a seizure, to get your pants down is really
Yeah.
fucking hard. So like I just see like why that, even though that rescue med has been around for so long, possibly not the most prescribed or recommended thing, because it's like, well, what is the point? Like you said, it could do
Right.
even more
And so
harm.
what we did instead was we prescribed other medications. They're all benzodiazepines. So I'll back up again because you asked kind of what is a rescue medication. And the rescue
Yeah.
medication, all the ones that we have are benzodiazepines. And so what that means is they work very quickly to try to stop the seizure. To go more into it, and you can take or leave this part, but so seizures happen because there's either too much excitation or not enough inhibition. So seizures are actually too much of a party, if you want to think about it. They are like a synchronized, abnormal electrical firing in the brain that grows. It invites more people to the party for it to grow.
It's
Right?
just a rager and in your
And
head.
then becomes
Yeah.
cool, right? It
Keg
grows and evolves.
stands.
Exactly.
Yeah.
And so the idea is that you want to stop that before they can go invite their friends, right? So you want to essentially shut it down, or at least this is how I feel, shut it down as soon as possible, because you can get to a point where it's harder to shut down. And so what these benzodiazepines do is they increase that inhibition. They try to stop the evolution and the spread of the seizure. But if you wait, it's much harder. It's almost like the horse is out of the barn, and once it's out of the barn, you can't bring it back.
Yeah, no, okay, this makes a lot of sense just in my own personal experience, because I do have a benzodiazepine that I take. Um, Usually it's after a seizure, because there's just no, during it is just too hard. But there are times I go into immediate denial after a seizure. I'm like, that wasn't a seizure. That wasn't a seizure. That was not a seizure. And so sometimes I will wait longer to take it. And I do think and there have been like a few times where I've gotten it like while the seizure's happening and have seen like a big difference, but it's just so hard to get it, like, I don't know, in that moment. And there's been times where I was like, I should have taken it because I felt the aura, but I was like, maybe it's just, I don't know, my brain being silly.
Well, and absolutely right. I mean, no one wants to have a seizure. You're going to be in denial. No, right? I'm just maybe a little sick, or I feel off, or right. And so, and by the time you might realize it's a seizure, it might be hard for you to give it. And that's where the caregiver role comes in too. And so we have, in our community, we'll say, some people may still say wait 5 minutes. I've slowly changed my recommendation. So I used to say wait 3 minutes. Then I said wait 2 minutes, because there was data that was coming out saying the sooner you give it, the quicker it will stop. And then now, with the amount of people that I have talked to, and with me alone, I have 2 small kids, and I think about if my child had a seizure in front of me, or my family member, could I wait 5 minutes? There's no way. Like, realistically, I don't think I could. And I can't imagine not only the person going through it, but the caregiver going through it. So that played a role. Then, sometimes people didn't give it because they thought that people were going to be more tired, or they were worried about breathing issues. But other things have shown that, when they're tested in clinical trials, respiratory depression is the words we use, that's studied and looked for. And doses are recommended accordingly to avoid that, to make sure that doesn't happen. And that's why you have certain instructions. But then with these newer, as you said, newer formulations of nasal rescue, what happens is it actually gets in the system a lot faster. It's more focused delivery, and people actually recover quicker. So in clinical trials, people will say that they recover within 60 to 90 minutes back to baseline. But I've seen that, now I bring it anecdotally back to what my patients say. So I saw a guy yesterday, and it used to take him over a day to fully get back to baseline. He and his wife were like, I'm back to normal conversation in 15 minutes.
15 minutes, that's nuts. And like the fact that it just works faster. So like, Oh,
So there's one other
sorry,
thing.
go
So
ahead.
the other
Yeah.
thing that
Oh,
I've had
good.
people
Yeah.
say, and again, this is more anecdotal, is I have had people say that if they take it right away, they are actually less tired and they recover quicker than if the seizure had progressed.
Oh, well, that makes sense because the full seizure didn't see itself through. Wow. Okay. Holy shit. That's amazing.
Well, and wait, sorry. And then here's the other thing is like the seizure may only last to someone observing it 30 seconds to a minute or two, right? But the people experiencing it, the aftermath can last hours or even days. All providers have different recommendations. So whatever I'm telling you is my own experience and my own recommendation. But for me, after getting feedback, right, I've been prescribing rescue medication even before 2019, but now I'm able to prescribe FDA-approved rescue medication and able to give more data from their clinical trials. And so what I tell people to do, because in the instructions, at least for the nasal rescue medications, is that you can use it once every 5 days, no more than 5 times in a month. So one of them is like once every 3 days, and the other's like once every 5 days, but both of them are no more than 5 times in a month. So for me, if you have seizures less than 5 times in a month, and most people have maybe 2 or 3 a month, I feel like. Some people have more, obviously, and some people have different types of epilepsy that can have 80 in a month type of thing. But on the average, if you have less than 5 seizures a month, I will say to take it right when you feel it, because the fear that we've had that people are going to be too tired or not get back to their baseline, I'm seeing anecdotally that is not a reality. Patients feel less tired, they're returning back to their baseline, they're returning back to work, they're returning back to life much sooner.
Well, and that's the part I really want to pause and note because I just appreciate how it's not just about the seizure. It's about getting back to life, which I think is such a huge detriment to, people living with epilepsy. I know for me, it takes usually 4 days before I can come out of it fully. I mean, every day gets a little bit better, and then, it's even like with like a month after a seizure, I'm like, oh, I'm feeling better than I was a week ago. It just takes a long time for brains to recover. And I just appreciate the holistic view that you're taking on this, that it's not just about that specific time frame of the seizure, which also seems to be like the immediate recovery time seems to be even better, which is just it's just amazing. And I'm like, how did I not know about this? But then I guess, so then leads me to the next question is like, who, you did mention that, if you're having like 5 or less seizures a month, right? Then that would be a person that might be like a candidate for it. But who else would you say is like a candidate, for this?
So typically I will say, anyone who has a history of a generalized tonic-clonic seizure, anyone who has a history of clusters. So when I evaluate someone, I will say, have you ever had more than one seizure in a day? Or anyone who has a history of status epilepticus, so multiple seizures where they had to go to the hospital and it be stopped with potentially IV medication. That's what I use. I always ask, have you ever had a generalized tonic-clonic seizure? Have you ever had a cluster? Or you've ever had seizures that did not stop on their own and you needed to go to the hospital? If anyone says yes to those, and that's a lot of people, then I will talk to them about a rescue med. And again, your practice evolves. So I used to pick and choose who I talked to about a rescue med. And then I realized, like, why am I the gatekeeper, right? Why am I the one that's deciding whether you need a rescue med or not?
Oh, yeah. I love that. Why am I the gatekeeper? That's just a beautiful self-realization that I never would have thought of.
If you have a rescue med, ideally it gives you some form of empowerment. And what I mean by that is that epilepsy is an unpredictable disease. It's probably the reason that it is so debilitating. Because if you think about it, like if you knew you were going to have a seizure the first Monday of every month at 3 p.m., it'd be a different disease, right? You wouldn't drive. You wouldn't hold your podcast then, right? You'd go lay down in your room. Right?
Yeah, that sounds kind of dope.
Yeah, right?
Scheduled seizures. Yeah. I'll take
But
it.
it's that unpredictability that takes away the independence. Oh, you could drive, right? You just don't drive at 3 p.m. on Monday, right? It's the unpredictability that takes away that independence. So for me, I cannot take away that unpredictability. But what I can do is I can give you something predictable to do in an unpredictable world. So I might not be able to stop your seizures, but if you have a seizure, I can give you a predictable rescue plan and a seizure action plan, something predictable to know what to do if you have a seizure or if your loved ones witness you having a seizure, because it is scary. And I don't care how many seizures you see, when you are right there with the person you love, or even for me, even in the epilepsy monitoring unit at bedside versus watching a video, it never gets less scary for me.
And that's something I really appreciate you bringing into the conversation as well, is just the caretaker's perspective, whether that's the doctor at the moment, like yourself, or whether that's, your mom, your roommate, your partner, whoever it is, just kind of viewing that and it being, and just looking at, taking in their emotions, that it is scary to watch and it is scary to be a part of. And I imagine really sad too, because there's nothing you can do. But wait, maybe you could help them with a rescue med. Possibly. So okay, like this is just so eye-opening right now. So how, like, let's say I want to talk to my doctor about this. And, okay, so I'm actually going to be a little bit more transparent. I did actually talk to a PA about this probably a year or so ago, and was kind of just shot down and was like, no, you don't need one. And then I felt very dumb and was like, okay, well, she knows more than I do, and then but like you said, just having that predictability in an unpredictable world, it reminds me a little bit of my EpiPen, because I have a peanut allergy. So I carry an EpiPen with me everywhere I go, along with, my benzodiazepines and Advil in case I have a seizure. All that stuff just travels my purses and comes with me. So it almost feels like it would be kind of nice to have this as well, just to try and see if it works, But when, it's one thing to ask your doctor, but then it's another thing to get, and not that my doctor shot me down, but someone in that office did. What do you recommend to like kind of try and push for it?
So that's hard. So it depends on how comfortable you feel, right? And so you could ask them, well, what's the negative of having one? What's the downside? Right? So that's not like, why are you saying this, right? It's just saying, can you help me kind of understand, like, what would be the downside of me having one? And they might say, well, and we're the ones that are giving you the number, right? So it's not like if someone were to say you're getting addicted to them, well, we're the ones giving the prescription, right? We're the ones saying how many refills. So we are the gatekeeper in that respect. But again, you're not supposed to have it at most more than once every 5 days, and that is really meant to be used intermittently, not every day, which should reduce the risk of potential overuse, abuse, misuse type of thing. So maybe they'll say that, or maybe they'll say you'll get too sedated. But as I said before, I think that those may have been misconceptions, because I know when I gave people Ativan and clonazepam, they'd say they were out of it for the whole day. It's a different ballgame now.
Yeah. Yeah. I mean, I start and end my day with benzos. So like, that's, it's like, trust me, I'm out of it. And then I take one after a seizure. So, it's done. It's game over. So I just think, just kind of just saying like, what's the harm in trying is kind of, and maybe just even getting more pushy and just being like, I really want to try this. Like, or then maybe finding someone else. I don't know. It is so weird, because like you said, like I've never looked at anyone in the medical field as a gatekeeper until this moment, and it's very true. I just never thought about it that way.
I think it's talking to the provider first, right? And the lessons, anytime you're in a situation where you might not be hearing something that you want, the first thing is to talk to the person about it and try to understand. So could you explain to me, like, what would be the downside of having this? How could this hurt me versus help me? And then say, well, is there a way that I could just try it? The nasal sprays, actually, their shelf life is like a year or more, right? And sorry, 2 years or more. The shelf life is 2 years or more.
Oh, wow.
So even with one prescription, if you don't use it, but you have it, no, just like your EpiPen, you have it in case. You have that a little bit of predictability, that empowerment, that a slight reduction in anxiety because you know what to do.
Yes.
Right? And that's the other thing too, is you could bring it up and you could say, well, the way I look at it is that, when I have a seizure, it is debilitating for me. It takes me 4 days to recover. If I could try to stop it sooner, maybe I can get back to my life sooner. And here's the thing is like, we need to document. Someone would have to document why you weren't a candidate.
Okay. So can I ask for that? Can I be like, how are you going to document? So, or is that just like being like, I never want to come across as like I'm judging you or I am, like I know better than you. I'm never trying to do that with, anyone who is in my medical team. But it is sometimes frustrating when you're like, how how are you the one stopping me?
I mean, we know a lot about epilepsy, right? And we know a lot about the medications, and I just had a conversation today with one of my patients this morning. You understand and know your seizures better than us. You live them. And in fact, the reason I love your podcast, and I think I've told like 5 or 6 people since like yesterday about it, is because it gives me more insight into living with epilepsy, right? Like, when I am in a doctor's visit with someone, it's a different conversation. But when I listen to you talking to some other high-powered individual who has, overcome this stigma, and hear you guys joke about it, right? Like, there was one where you guys were talking about your aura, like, oh no, if you get an aura, like hurry up and cook dinner, or hurry up and send that email, right? Like, I'm not part of the party, right? Because I can't ever fully 100% understand it. I can understand it through the eyes of you. But with listening to your podcasts, it's eye-opening, right? And so it gives extra insight. And for that, I'm saying all this to say that we as providers can never 100% fully understand what you're going through. But you can try to help us.
I love that. And I appreciate you saying that, a patient knows their seizures better than anyone else, because sometimes I feel like, and I know I'm not alone in this, but some people get questioned too, about, or sometimes the response will be, well, that doesn't make sense, and it's like, I get it. There's probably no research to back this up, but this is my experience, so I really appreciate that. And I like the idea of almost looking at it as like a benevolent gesture, like, here, let me help you understand epilepsy better by giving you my experience, and just really just opening the lines of communication. It seems.
No, but
Go ahead.
Understand your epilepsy better, right? Because everybody's different, right? No two people have the same exact seizure. You might both have seizures coming from your temporal lobe, right? But no one has the exact same thing happen. And how many times do you try to describe it and you're like, I just can't describe it because there's no words, right? And so
Yep, all the time.
Right.
All the time. That's always, because it's just like, well, what does it feel like? And I'm like, I don't know what to tell you. Like, I just don't know how to explain this.
And the only other thing I'll say, and I know this because I feel myself do it too, when I walk into a room, I don't want you to have epilepsy either, right? So I'm going to go in the room hoping it's not epilepsy. So I'm going to ask you questions to try to figure out if it is. And I do think it's in the delivery of how people ask questions, but a lot of those questions are just trying to figuring out like, okay, is this really epilepsy? And if this is, and the drugs aren't working and things like that, then the conversation changes. But it's all about a conversation.
Yeah.
And so I think it's very important. And I will tell you, it's also about what's taking away from your life. So here's another way that you could address your provider, like in the things that epilepsy takes away. So I saw a patient who had not had seizures for 7 years. She had stroke and she had multiple seizures. She got on the right meds and she's been seizure free. But she still lives in fear that she's going to have a seizure. And she used to teach Sunday school, and she stopped teaching because she was so scared she'd have a seizure in front of the kids. And so I asked her if she would want a rescue medication. I told her about what it was, and I said, is this something you would want? And she said, absolutely. Because knowing that I have that, I feel like I could go back and teach Sunday school again, right? And that's what made her happy.
Wow. And what a wholesome thing. I just want to teach Sunday school, Like, it's not even like, I just want to go belay down a mountain. No, I just want to teach Sunday school. That's pretty beautiful.
So as a provider, we our goal is seizure freedom a lot of the time, right? Like that's your goal too, but that's not always a realistic goal. And or what I should say is, ideally what happens is when you first come to us, our goal is to get you seizure free with medication. And then sometimes those medications don't work. And then other conversations come in about other non-pharmacologic options. But our goal a lot of time is still seizure freedom. But conversations need to shift. And so I've had multiple patients that I have not been able to get seizure free. And I may have had those conversations about neuromodulation or surgery, but they do not want it. And I can understand that too. It's brain surgery, right? So I had a patient and they do not want brain surgery. And I've been able to reduce their seizures. They used to have 5 or 6 a week, and I've been able to reduce it to 2 a month. So when they have 1 or 2 a month, they take the rescue medication right away so that they can stop it in its tracks. And so I haven't been able to stop their seizures, but I've been able to get them again back to life, because if they have one, they take it right away, and then they're able to get right back to life. It doesn't progress. So there's goals that need to shift.
This just sounds like magic. It sounds like some Harry Potter wand you stick up your nose, and then you're fine.
That would be amazing. That needs to be a new picture.
Yeah. Wow, and that's very relatable, because I think a lot of people, myself included, are kind of at that point where it's like seizure freedom is probably not in the cards at this moment with what is out there. But being able to stop a seizure, being able to, and then resume normal life, because sometimes that's not even, it's I lay down for 4 hours afterwards, and fall asleep because I'm exhausted and that whole thing. And that's not okay, a nap isn't the worst thing in the world, right? But then it's the next 4 days to follow that are. So I think that's just so amazing that it's this is just stopping the party. It's, it's like the mom coming in and being like, everyone's kicked out. This is done. Bye. Get out of my house. Yes. That's amazing.
So, I do have to say, this isn't, it's not a silver bullet in the fact that it works for everyone. I definitely have patients that have used it and their seizures may have still progressed, right? Or it didn't stop it. And we know that can happen. And that's also why I say to try to take it as soon as possible, because I want the best chance of stopping it.
And how is that? How does that logistically work? Is it usually a caretaker that gives it? Is it you feel an aura and start and then do it? What is the, because I know for most of my epilepsy career, I lived alone, so having someone else do it wasn't really an option. So what is that? Yeah, what is that?
So it's different for every person. So I will sit down and talk to them and talk about, okay, what's the first thing you feel? What happens, right? And I'll also talk to them about, what are the seizures that they have? If it's a deja vu and it stops right away and they're back to their baseline, that's not something they're going to necessarily take a rescue medication for, right? But if it's deja vu that always progresses to focal impaired awareness seizures, that always progresses to the big words we use, focal to bilateral tonic-clonic seizures, right? It's the pattern they have. Mm-hmm. And so I will help them, I will walk through a plan of, what type of seizures they have, how debilitating they are, how severe they are, how often they have them. And so if there's an aura, but that aura is always followed by something, then as soon as you have that aura, you go and get the rescue medication. I had a patient where I used to be that he would get an eye twitch, and then he'd wake up in the hospital. And so I said, you go take that medication as soon as you have an eye twitch. And so then he told me a story about his wife went to go pick up the boys from a bus stop, and he felt the eye twitch. He went and laid down. He took it. He woke up a couple minutes later. So
wow.
And that's not everybody, right? But this is the goal.
Right. Totally. Yeah, and something that I don't know, from my personal perspective, feels like something worth being pursued to at least try, like you said, it may not work, but like, why
And what
not
do you have
try
to
it?
lose? Like that's
Yeah. Yeah. Well, that is my this I'm so glad you said that because I've been wanting to ask you and I just keep forgetting. Have there, what's the research and what have you noticed about any like adverse side effects? We've talked all about the good stuff, but what are the things that people might
right.
be afraid of?
So some people will say that they can get headaches. Some people can say they can get dizzy. They can get sleepy. They can have nasal discomfort with these particular ones or a weird taste. But the biggest thing that people are scared about is not being able to breathe, right? Having too much of a benzodiazepine, and then we call it respiratory depression, right? Like something bad could happen that you couldn't control. So,
Oh,
but that's why it's
okay.
studied in clinical trials, and that's why, so for one of the medications, it's age and weight based, and for another medication, you give a certain amount, and then you have to wait to give another certain amount, and all of that is to
Okay.
avoid those adverse events that people are most scared of, right? So it's tiredness and losing your day, but if your seizure fully progresses, you're going to be tired and lose your day anyway. And it is respiratory depression, but clinical trials have shown that when given us, the way is recommended, that there was no clinical respiratory depression, right?
So it's about like really just making sure following instructions to whoever you're using and now I understand the whole like once every 5 days, like trying to really just make sure there's no, because it sounds like a dependency could possibly develop just was with
Right,
any
with any
benzo.
benzo. And the other thing is you want it to work when you need it. And so if you take a benzo every single day, one, stopping the benzo could cause a withdrawal seizure. But two, then we use the word habituate, which means like your body could get used to it and then it could not work. Those receptors that you want to cause inhibition, if you use it all the time, you might lose some of those receptors, right? You want to keep them hungry.
Okay. Got it. Okay. Wow. Thank you for like breaking this all down. I feel like this because I am so bad with like anatomy and science and all this stuff, but I'm fully following here. Yeah.
You're
Yes.
like good
Thank you.
analogy.
I'm always like, talk to me like I'm five. Talk to me like I'm five. I don't understand any of this, but I do. So thank you. Is there anything else you want to add? Because I've got some completely unrelated questions I would like to ask you. But anything else that you feel like we just need to
No,
tack
just
on
to
to this?
say, I know it can be hard and daunting to bring up something to a provider that they might not have brought up, but you are your best advocate, right? And this disease has taken so much from you that you absolutely have the right and need and necessity to communicate your disease and what it does to your life and fight for what you need to get your life back as much as you can.
Thank you. I just appreciate the compassion and understanding. And for educating the hell out of me on rescue meds. And I know other people too. I know I'm not alone on this because I've talked to people. I'm like, what's your rescue med? They're like, what? I'm like, right? I don't know what it means either. It's like a secret thing. Harry Potter is involved apparently. Okay, so I've got 3 questions I want to ask you that have nothing to do with anything
Okay.
we've just talked about. Number 1, what is your favorite color?
Green.
Okay, I love it. Is Okay, I gotta ask why though. I can't not. Every time I ask their
I
favorite color,
know,
I just
right?
want to
So
know
for me,
more.
so water relaxes me. And when I see an ocean, and it's kind of like almost like that sea green kind of aqua, like when I see that, it's just so relaxing to me. And I don't know why. Now I'm not near water. I'm just near, now I'm just near tons of evergreens or trees and things like that. But that relaxes me too, right?
Okay, number 2, what is a favorite show or movie that you could just rewatch over and over and over? And this is a no judgment zone. You can name the worst TV show or the worst movie, and I want to hear it with pride and be like, yes, this is my thing. You cannot judge it.
So I will tell you that right now I do have two small children. So to be able to watch something again is not.
You're like, what world are you
So right
talking
now
about?
it's like Frozen and Moana. And I do love the songs of Moana. So I have to say,
Okay, there we go. Well, that is, I mean, it is like which movies do you hope your children choose to watch? Because they're the ones choosing, right?
so anything
Okay.
with music
Okay,
and
so
singing I love.
And number 3, what does it mean to you to be a friend?
unconditional love, right? So someone who's always there for you when you need them. And it can be someone, and as lives get busy, as we say, that like I might not have talked to for a couple of months. Or I actually have someone who just took a position here at OSU, and I haven't seen her in 10 years. And we had dinner for the first time 2 weeks ago, and I was like, it was like no time had changed, right? So it's those people that you can be your true self to, that you can count on, who love you unconditionally, you love them unconditionally, and just make you smile.
It is the best when you have those friendships, like you say, months, and like you said, I think of friends you haven't seen in years, and it's just like nothing. No time has passed when you do see each other, and there's no like animosity about the fact you haven't seen each other, because you get that life just happens, and that's
then it warms
so
your heart. Like,
beautiful.
how excited are you after you've like talked to one of your best friends, or like even had a hard day, right? Like I have friends that if I feel bad and I call them, I could talk to them for 3 minutes, and it's like whew, they made everything disappear.
Yeah, it's like immediate serotonin. You're like, it feels like I just went to the gym, but I didn't. It was amazing.
Exactly.
I am so appreciative, Dr. Becker, of not only you joining this conversation and educating the hell out of me, and I know so many other people out there, but just like everything that you do for the epilepsy community. It's just it's so holistic, it's so beautiful, it's so heartfelt, and I really, really appreciate you. Thank you so much.
Thank you for the opportunity. I the message needs to be heard, and you are the one helping give that message. So I just appreciate the opportunity. So thank you.